Hello, my name is Dr. Alan Kerry. I'd like to welcome you to another podcast from the South Essex GP Training website. With me, I have Dr. Sunil Gupta, and we're going to discuss the NICE guidelines on when to suspect child maltreatment. For further information, please look at the National Institute for Health and Clinical Excellence website, which is at www.nice.org.uk. So, Sunil, what are the aims of these guidelines?
These guidelines provide a summary of the alerting features associated with child maltreatment. Its aims are to raise awareness and help healthcare professionals who are not specialists in child maltreatment. The guidelines do not describe how to diagnose, confirm or disprove child maltreatment.
So let's start with some definitions. What does child maltreatment include? Child
maltreatment includes neglect, physical abuse, sexual abuse, emotional abuse, and fabricated or induced illness.
So, what does it mean to consider child maltreatment?
To consider child maltreatment means maltreatment is one possible explanation for the alerting feature or is included in the differential diagnosis.
And what about when we say we suspect child maltreatment?
To suspect child maltreatment means a serious level of concern about the possibility of child maltreatment, but is not proof of it.
So what process is advised by these NICE guidelines?
This NICE guidelines advise a process with 5 stages. Number 1, listen and observe. Number 2, seek an explanation. Number 3, record. Number 4, consider, suspect or exclude maltreatment, and number 5, record.
Okay, so the first stage is listen and observe. What do the guidelines tell us about this?
They advise we should take into account the whole picture of the child or young person. Sources of information include history, report of maltreatment or disclosure, child's appearance, demeanour or behaviour, symptom, physical sign, result of an investigation, and the interaction between the parent or carer and the child or young person.
Can you tell us more about seeking an explanation? Particularly, what could lead us to consider an explanation as being unsuitable?
We should seek an explanation in an open and non-judgmental manner. We should seek appropriate expertise if we are concerned about a child or young person with a disability. An unsuitable explanation is one that is implausible, inadequate or inconsistent with the child or young person's presentation, normal activities, existing medical condition, age or developmental stage, or account compared to that given by parent and carers, or one that is implausible, inadequate or inconsistent between parents or carers or between accounts over time. NICE reminds us that cultural practice is an unsuitable explanation for hurting a child or young person.
What should we record?
We should record in the child or young person's clinical record exactly what is observed and heard from whom and when, and we should record why this is of concern.
The fourth stage in the process was considering, suspecting or excluding maltreatment. What do the NICE guidelines say about this stage?
When hearing about or observing an alerting feature, look for other alerting features of maltreatment, then do one or more of the following. Discuss with a relevant child health specialist or designated professional for safeguarding children. Gather collateral information. Ensure review at a date appropriate to the concern. Look out for repeated presentations of this or any other alerting features. At any stage during the process of considering maltreatment, the level of concern may change and lead to exclude or suspect maltreatment. So for suspect maltreatment, if an alerting feature or consideration prompts you to suspect maltreatment, you should refer to children's social care. This may trigger a child protection investigation. Supportive services may be offered to the family following an assessment, or alternative explanations may be identified. For exclude maltreatment when a suitable explanation is found for the alerting features.
The fifth stage in the process is record, and we should record all actions taken in the previous stages and the outcomes. I'd now like to discuss alerting features. What are the various areas of alerting features that we should be aware of?
The following forms of alerting features that may lead you to consider or suspect child maltreatment are physical features, sexual abuse, neglect, emotional, behavioural, interpersonal and social functioning, clinical presentations, fabricated or induced illness, and parent or carer-child interactions.
So starting with physical features then, when should we consider child maltreatment and when should we suspect child maltreatment?
We should consider when there's any serious or unusual injury with an absent or unsuitable explanation. We should suspect maltreatment when there's bruising in the shape of a hand, ligature, stick, teeth mark, grip or an implement.
When should we consider the possibility of sexual abuse and when should we suspect sexual abuse?
We should consider sexual abuse when there is persistent or recurrent dysuria or anogenital discomfort or an anal or genital symptom in a girl or boy without a medical explanation. We should suspect sexual abuse when there is persistent or recurrent genital or anal symptom in a girl or boy without a medical explanation that is associated with behavioural or emotional change.
And when should we consider the possibility of neglect and when should we suspect neglect?
We should consider neglect when parents or carers repeatedly fail to attend essential follow-up appointments that are necessary for the health and well-being of their child. We should suspect neglect when the child is persistently smelly or dirty.
And then emotional, behavioural, interpersonal and social functioning problems. When should we consider these and again when should we suspect them?
We should consider when there's unusual, unexpected or developmentally inappropriate response by a child to a health examination or assessment. For example, extreme passivity, resistance or refusal. We should suspect when there's repeated or cohesive sexualized behaviors or preoccupation in a pre-pubertal child, for example, sexual talk associated with knowledge, drawing genitalia or emulating sexual activity with another child.
What clinical presentation should make us consider child maltreatment and what clinical presentation should make us suspect child maltreatment?
We should consider child maltreatment when there is poor school attendance that the child's parents or carers know about that is not justified on health, including mental health grounds, and home education is not being provided. We should suspect child maltreatment when there is repeated apparent life-threatening events in a child, if the onset is witnessed only by one parent or carer, and a medical explanation has not been identified.
And fabricated or induced illness, when should we consider and when should we suspect fabricated or induced illness?
We should consider it when the child's history, physical or psychological presentation, or findings of assessments, examinations or investigations lead to a discrepancy with a recognised clinical picture, even if the child has a past or concurrent physical or psychological condition. We should suspect child maltreatment as above, plus one or more of the following: reported symptoms and signs that are only observed by or appear in the presence of the parent or carer, an inexplicably poor response to treatment, new symptoms are reported as soon as the previous symptoms stop, biologically unlikely history of events, despite a definitive clinical opinion being reached, multiple opinions are sought and disputed by the parent or carer, and the child continues to be presented with a range of signs and symptoms, and child's normal daily activities are limited or they are using aids to daily living more than expected.
What aspects of the parent or carer interactions with a child should lead us to consider or suspect child maltreatment?
We should consider child maltreatment when potentially harmful parent or carer child interactions are emotional abuse, including negativity or hostility towards or rejection or scapegoating of a child or young person, developmentally inappropriate expectations of or interactions with a child, including inappropriate threats or methods of disciplining, exposure to frightening or traumatic experiences, including domestic abuse, using the child to fulfill the adult's needs, for example in marital disputes, failure to promote the child's appropriate socialization, for example not providing stimulation or education, isolation or involving them in unlawful activities. We should suspect child maltreatment when there's persistent harmful parent or carer child interactions.
What do the NICE guidelines say about sharing information concerning children and young people?
NICE says good communication between all parties is essential. If worried, seek advice from designated professionals for safeguarding children. If concerns are based on information given by a child, explain to the child that you may be unable to maintain confidentiality, explore the child's concerns about sharing this information, and reassure the child that they will continue to be informed.
So what obstacles need to be overcome in order for us to prevent harm being done?
NICE identifies several obstacles. These include concern about missing a treatable disorder, fear of losing positive relationship with a family already under care, divided duties to adult and child patients and breaching confidentiality, an understanding of the reasons for the maltreatment and no intention to harm the child, losing control over the child protection process and doubts about its benefits, and stress, personal safety and fear of complaints. But NICE says these obstacles should not stop us acting to prevent harm.
Thank you. Both Sunil and I would like to emphasise again the importance of looking at the NICE website itself for the detailed, up-to-date advice, and we'd like to thank you for listening to this podcast.